Good afternoon. Today I thought I could actually take a gist of all the cirrhosis and viral hepatitis which I have told you. I was not sure whether what I have taken is clear. So I thought I will just take another gist of all the three classes together again. So this was what we started with. Yes, this is jaundice, right? So what is jaundice? It is a yellow discoloration of the skin and the sclera due to excess serum bilirubin, which is more than 3 mg per deciliter. And then we are having two types of hyperbilirubinemia. It can be conjugated and unconjugated bilirubinemia, obstructive or non-obstructive hyperbilirubinemia. And this jaundice can be again pre-hepatic, hepatic and the post-hepatic types. So jaundice need not always tell you that it is a liver disease, but usually jaundice you equate it with liver disease. Okay, so when measured by modifications of original Vandenberg method, the normal values of total serum bilirubin are 1 to 1.5 mg per deciliter, and almost 95% of the population it falls under 0.2 to 0.9. Okay, if the total fraction is less than 15% of the direct acting fraction is less than 15% of the total, the bilirubin can be considered to be all indirect. Yes, so if the direct acting one is less than 15%, it is the bilirubin is considered if the direct acting fraction is less than 15% of the total, the bilirubin can be considered to be indirect, right? The most frequently reported upper limit of normal for conjugated is 0.3 mg per deciliter. Okay, and then isolated unconjugated hyperbilirubinemia, when it is elevated but less than 15% of the direct, it should prompt a workup for hemolysis. In the absence of hemolysis, an isolated unconjugated, that means the isolated unconjugated hyperbilirubinemia should be less than 15% of the direct. If it is so, then this is called as unconjugated hyperbilirubinemia, and it is many times it is seen in Gilbert's syndrome. Okay, and again when we are having conjugated hyperbilirubinemia, okay, most of the times it is that the rate limiting step in bilirubin metabolism is not conjugation of the bilirubin, but it is rather the transport of the conjugated, that is from the hepatocyte coming into the bile canaliculi is the rate limiting step. So whenever you are having an edema of this bile canaliculus, that is which you can see even in the hepatocellular failures, there can be a rise in the conjugated hyperbilirubinemia. That is the reason why when you are having acute viral hepatitis, though it is a hepatocellular disease, you are having a mixed pattern, conjugated and unconjugated both are increased, because this is the thing, because the edema of it will not allow the conjugated bilirubin to be secreted, right? Now, so again anatomically the dysfunction of your liver can be divided as loss of hepatocyte integrity. The hepatocyte itself, there is a loss of integrity, that is that hepatocyte gets broken up, or it can be the biliary excretory function, that is from the bile canaliculus, canal of Herring and the bile ducts there is some excretory problem, that is there is an obstruction somewhere, that is obstructive jaundice, and the loss of hepatocyte function. This occurs in chronic hepatitis. Okay, now coming to the LFT. So how do you decide these three into which category we can put the disease? By doing an LFT. So serum enzymes when they are raised, that is especially ALT and AST, when they are increased 10 times the normal, 40 units per liter is your normal. If it is increased 10 times, you take it as hepatocellular injury and necrosis. And then coming to the test of biosynthetic function, it is usually the albumin and the globulin which you look at to see how much of the liver hepatocyte is functioning. If there is a failure here, then it is that the chronic hepatitis is going into liver failure, right? And then tests of cholestasis, it can occur even in acute liver failure. Okay, even your coagulation factors, which can be assessed by your PT. This is another test which is actually prognosticating the cases of liver failure. And now coming to the tests of cholestasis. Here, three enzymes are usually taken as tests of cholestasis, that is alkaline phosphatase, 5-nucleotidase and glutamyl transpeptidases. Now, alkaline phosphatase and 5-nucleopeptidases are found in or near the bile canalicular membrane of the hepatocyte, while GDD is located in the endoplasmic reticulum of the bile duct epithelium. Okay, are you getting the point? Here, alkaline phosphatase and 5-nucleotidases are in the bile canalicular membrane of the hepatocyte. So, bile canalicular membrane is made up of the hepatocyte. Okay, and while GTT is in the endoplasmic reticulum of the bile duct epithelial cell. So, reflecting its more diffuse localization in the liver. Okay, so GDT elevation, GGT elevation in the serum is less specific for cholestasis than when it is for alkaline phosphatase and 5-nucleotidases. Okay, but however, some of them use GGT as a marker for alcohol use, occult alcohol use, right? Now, when we come to the liver functions, we can divide them into functions of metabolism, functions of secretion, functions of excretion, functions of synthesis, functions of storage, and some functions of detoxification. Now, I think I've told you this in the previous class also. When you learn about the liver functions, then you can correlate with the dysfunctions. So, when you are having a liver dysfunction, jaundice and cholestasis, this can occur in all the three we said, hepatic, prehepatic and posthepatic diseases, right? And then hypoalbuminemia, synthetic function loss, hyperammonemia, detoxification is affected, hypoglycemia, metabolism is affected, fetor hepaticus means that the ketone bodies are in excess. Then palmar erythema, spider angiomas, hypogonadism, gynecomastia, these are all the diseases which are occurring because of the excess of the because of hyperestrogenism. Where is this estrogen coming from? The androgens which are in the circulation, they get converted to estrogens. Okay, that is where you get this hyperestrogenism. And then we also have weight loss and muscle wasting in these cases, and that is the hepatic dysfunction. When you look at cirrhosis and when you look at the liver dysfunction, this liver dysfunction can be again with cirrhosis and without cirrhosis. When do you decide that the patient is having a cirrhosis? When you are having a portal hypertension, that is when you say that the patient is having cirrhosis. So, how do you say that the patient is having portal hypertension? When you are having ascites, when you are having splenomegaly, and when the patient is complaining of hemorrhoids and also esophageal varices, caput medusae. When you examine the patient, you will know it. Okay, so when you are feeling a spleen in a case of cirrhosis, when you are having ascites, when you are having hemorrhoids, and when you are having caput medusae, that is that the patient is having portal hypertension and the cause of liver disease could be cirrhosis. Okay, now what happens in the cases of acute liver failure or life-threatening complications of acute liver disease or your chronic diseases with liver failure? Here we have what is called as hepatic encephalopathy, right? Hepatic encephalopathy. Coagulopathy is because your coagulation factors are not being synthesized up to the necessity, up to what is necessary, right? Hepatorenal syndrome. Okay, here these three are the life-threatening complications. We also have bleeding from portal hypertension. Okay, so when you are having a hepatic failure, what are the things which you have to monitor in the patient? The PT, because this might cause lots of internal bleeding. The prothrombin time is one of the prognostic markers. Then we have hepatic encephalopathy. What is hepatic encephalopathy? There is loss of there is loss of cerebral higher functions because the ammonia which is there in the blood is not being detoxified. Then the third one is your hepatorenal syndrome. What is your hepatorenal syndrome? Because you are having a lot of decrease in the albumin and the change in the dynamics, hemodynamics. What is happening? The intravascular volume is getting reduced and it goes into the extravascular compartment because hypoalbuminemia is less. And when that is happening, what happens? There is an excess of compensatory mechanisms which cause arterial and venous constriction. This again causes an increase in the it causes again the shift of the water to the extravascular compartment. So finally what is happening? This will reduce the renal blood flow and this is causing a hepatorenal syndrome. As such, there is no intrinsic renal disease, but it is only that the kidney is getting shut down because of the changes in the hemodynamics and changes in the hormonal balance in the body because of the hepatic disease. These are the three very acute problems which a patient can die of. And the fourth one is a ruptured esophageal varus. Now coming to hepatic failure. What is hepatic failure due to? Sudden and massive hepatic destruction, or it is an end point of a progressive damage like in your cirrhosis. Okay. Now, so the hepatic failure can be chronic or acute, right? So sudden and massive hepatic destruction or end point of the progressive damage of a chronic liver disease. Now, so acute and chronic liver failure, hepatic failures. Now, what is hepatic encephalopathy? It is manifested by disturbance in consciousness. It could be just that the patient is confused. He can be in a stupor. He can just have a small difference like his sleep patterns are changed, and or it can go into a deep coma. Okay, and these will progress over hours or days into fulminant hepatic failure, and then usually it is associated with fluctuating neurological symptoms, and you have hyperreflexia and asterixis. I think the clinical classes would help you learn what are all these neurological symptoms. And this hepatic encephalopathy is regarded as a disorder of neurotransmission, and it is associated with elevated blood ammonia levels. As in a normal person, the liver is actually removing the excess of blood ammonia, and it is detoxifying our system. But in hepatic failure, this ammonia will reach the blood. Normally this ammonia, we are having a tight junction. We have a blood-brain barrier, and this ammonia will not reach the brain. But in cases of hepatic encephalopathy, it gets an access into the brain. That is called the that is the reason of hepatic encephalopathy. So the toxins, N2 metabolites, ammonia comes from where? From your amino acid metabolism. So this is detoxified into the brain and it doesn't go to the brain. Now in cirrhosis of the liver or in portosystemic shunts or in your hepatic failure, what is happening? These metabolites reach the brain and this cause a change in the neurotransmission of the brain. Yes, the hepatorenal syndrome. Now what is this hepatorenal syndrome? The appearance of the renal failure with severe chronic liver disease in whom there is no intrinsic or morphologic or functional cause of the renal failure. There is a renal failure, that is oliguria develops, but intrinsic morphological or functional disease of the kidney is not present, and this is because of the sodium retention and impaired free water excretion and decreased renal perfusion and glomerular perfusion rate, which cause this functional abnormalities. Usually there is a decreased renal perfusion because of systemic vasodilatation and activation of the renal sympathetic nervous system. And why is this? Because of this is because of the shift of the vascular decrease in the vascular volume because of the shift of the fluid to the extravascular space. Okay, onset of this syndrome is typically heralded by drop in the urine output and associated blood urea nitrogen and creatinine increase. And the ability, how can you say that the kidney is not having any functional disorder? The ability to concentrate urine is retained. This is one of the major functions in the kidney. So the ability to concentrate urine is retained. So that is the reason why we say that there is no renal dysfunction, but intrinsic renal dysfunction, but because the blood is not coming, enough blood is not, the GFR is not normal, that there is a renal decrease in the renal output. The prognosis in these cases is very bad actually. The survival is only 2 weeks from the onset of the decrease in the renal output. Now that was acute hepatic failure. Now what is that which is causing hepatic failure? It is the cirrhosis. So what is cirrhosis? It is the end stage liver disease where there is a complete loss of architecture, fibrosis and regenerating parenchymal nodule which is occurring. And this end stage liver disease could be because of alcohol. 70% of the times it is alcohol abuse, induced cirrhosis. Then we can have in 10% each we have viral hepatitis and biliary disease which is causing cirrhosis, and metabolic disorders which are also causing cirrhosis, right? And then the we have a morphological classification in cirrhosis, that is micronodular and macronodular. Usually the alcoholic cirrhosis is micronodular, whereas others are macronodular and mixed. So the etiology is alcoholism, viral hepatitis, metabolic diseases and biliary diseases. The others being not very common in our setting. Okay. So coming to the pathogenesis of fibrosis. Why does the pathogenesis occur? Chronic inflammation is leading to the formation of tumor necrosis factor alpha, transforming growth factor beta and interleukin 1, and we are having cytokines being released from Kupffer cells, endothelial cells, hepatocytes and bile duct epithelial cells, and the disruption of the extracellular matrix and the toxins, all of them are leading to the stimulation of the eto cell. This eto cell is a dormant cell which is lying dormant, and it is having only the function of storage of the vitamins. But once all of these act on the eto cell, it transforms itself into a myofibroblast, and this is leading to the formation of fibrosis. Okay, so this is your eto cell. See, this is your hepatocyte, this is your bile canaliculi which I was talking about. So the rate limiting step is this transport of your conjugated bilirubin into the bile canaliculi here. Okay, any disease, any swelling of the hepatocyte because of hepatitis will cause an obstruction to this bile canaliculus. Okay, right. So coming back to the topic, these eto cells which are present in the space of the disease. What is the space of the disease? The space between the hepatocyte and the sinusoidal endothelial cell. Okay, this is the sinusoid, and this cell is getting transformed into your myofibroblast. And how are it's by your transforming growth factors and tumor necrosis beta. From where are they being produced? They are produced from the hepatocyte, from the endothelial cell, from the Kupffer cell, and also from your disrupted matrix. This leads to fibrosis. Okay, micronodular cirrhosis is seen in alcoholic liver disease, whereas macronodular is seen in other diseases. What is this? Yes, micronodular cirrhosis. This is a mixed type of cirrhosis. Okay, so this is how your normal liver is from the portal tract. See, from here the bile is getting secreted. It travels through the bile canaliculi and the canal of Herring, and it comes here into the bile ducts. Okay, and your blood from the side through the sinusoids, it goes into the central river. When it is going through the sinusoids, what is happening? It is bathing the hepatocytes, and so whatever the synthetic functions, that is the albumin and the coagulation factors which are formed in the hepatocytes, come into the blood. and whatever from the portal vein, whatever toxins which are being brought will be removed by these cells, then it reaches the systemic circulation. But in cirrhosis, only the fibrovascular septa are being formed, and the nodules are and the hepatocytes form nodules, and there are no sinusoids there, and so there is a porta systemic shunt, that is from the portal vein the blood is directly flowing into the systemic circulation without going through the hepatocyte and without being cleaned up by your hepatocyte. Okay, right. So this is to show you the fibrosis. So there is a liver failure. Why? Because what all the synthetic functions of the liver, it is not finding an access into the blood. And parenchymal regeneration, when there is the death of the tissue, our liver stem cells come up and they start forming a regeneration. Portal obstruction and portosystemic shunts. Why? The fibrovascular structures, fibrovascular septae which are being formed, they are not as accommodative as your sinusoid, so they lead to portal hypertension and splenomegaly. And then we are having coagulopathy, hypoproteinemia because of your liver failure, and toxemia and encephalopathy because of portosystemic shunts, right? This is what is cirrhosis. Okay, hepatocellular failure, malnutrition and hepatoencephalopathy, and portal hypertension, which you can recognize by ascites and splenomegaly. Cause of death in these cases is again the same as in your hepatic failure, that is hepatic coma, massive GI bleed, intercurrent infections, hepatorenal syndromes and hepatocellular carcinoma. So that was about your cirrhosis. Now what is the cause of cirrhosis? For that we will just go into and find out what is this. Okay, when a 30-year-old patient who came with non-specific symptoms, he had non-specific symptoms like anorexia, nausea, vomiting, fatigue, like in any other systemic infection you will have all this since one week. Then he developed fever, then he developed dark urine and clay colored stools after 1 day. After a week or so, there is dark colored urine and clay colored stools which are being produced. What does this mean, dark colored urine and clay colored stool? There is an obstruction to the bile flow, right? So when there was a general examination, except the general examination was normal and your organ systems were normal, except that there was a tender hepatomegaly. So because of this tender hepatomegaly and this, our brain directly goes to a liver disease. Now a dull aching pain is usually a liver disease, but when you are having a severe pain, we should think of gallbladder disease, a liver abscess or a severe veno-occlusive disease, right? So if you look at the LFT in such cases, what is there? There is a direct bilirubin of 1.5 and 2 mg of indirect bilirubin. Then there is a marked elevation of both ALT and AST. Alkaline phosphatase is not very marked. And then there is no much decrease in the albumin. Okay, so this was a case of loss of hepatocellular integrity. Hepatocyte integrity, cell integrity is lost in these cases. And we said that, okay, what if the serum HBsAg is reactive? Okay, this could be viral hepatitis. Actually this slide should come before. It could be because of viral hepatitis, it could be because of ischemic liver disease and toxin induced liver disease. So okay, so this picture, this LFT picture can occur in these three conditions. Okay, so now if this patient is HBsAg positive, that will tell us that it is viral hepatitis. Now what is viral hepatitis? It is reserved for infections of the liver caused by group of viruses that have a particular affinity for the liver. Those are hepatotrophic viruses. We are having 5 hepatotrophic viruses. HAV and HEV are fecal-oral route, whereas B, C and D are the parenteral route viruses. And now HDV, that is hepatitis D virus, is a defective or it is a defective virus which requires the co-infection of HBV to get itself infected, right? So acute viral hepatitis is characterized morphologically by combination of inflammatory cell infiltration, macrophage damage, hepatocellular. So we describe the classic acute hepatitis as a necrosis and inflammatory lesion of the parenchyma, okay, and then the proportion of this necro-inflammation of the parenchyma is going to decide what is the fate of acute hepatitis. So in this necrosis can be spotty, it can be bridging, it can be periportal necrosis or a panlobular necrosis. It is spotty necrosis in most of the cases of acute hepatitis. Bridging necrosis in a little more severe pattern. Periportal necrosis and panlobular necrosis are the ones which are having a more severe form of hepatitis at the brink of failure, and when you are having a panlobular or massive necrosis, the patients will have acute liver failure, okay. Now along with that necrosis, the patient also has ballooning degeneration and Councilman bodies in the liver, and the inflammatory cells are usually lymphocytes and plasma cells. Acute inflammatory cells are usually polymorphs, but in cases of viral infection and in the viral hepatitis, it is lymphocytes. It is because these lymphocytes are acting against the viral antigens, okay. These are stimulated and attracted by the viral antigens, which are and that is the reason why we have lymphocyte infiltration in acute viral infections. Not only in acute viral hepatitis, even in other acute viral infections, it is the lymphocytes only which is the cell, and usually they are more prominent near the central vein, okay. And now what happens in cases of acute hepatitis? If it is the classic spotty necrosis hepatitis, it goes back to normal, okay. If it is panlobular, it goes to death with severe liver damage or its complications. If it is bridging type of necrosis, or it is a periportal necrosis type, it goes into post-hepatic scarring. And then you also have a carrier state, a chronic hepatitis and cirrhosis stage, post-hepatic scarring, okay. And then you can also have a chronic hepatitis, and when there is this scarring continuously going on. Chronic hepatitis means nothing but acute hepatitis with the features of your scarring which is occurring continuously, and when this ends up in cirrhosis, the patient will again have chronic liver failure, okay. And in some patients, these patients can have hepatocellular carcinoma. Coming to fulminant hepatitis. Now what is fulminant hepatitis? When hepatic insufficiency progresses to fulminant hepatic failure in 2 to 3 weeks, it is called fulminant hepatitis. And what are the causes? It is the hepatitis viruses A, B, C and D. The drugs also can cause it. Ischemia, hyperthermia, any one of them can cause fulminant hepatitis. Like how cirrhosis can be caused by so many diseases, even your fulminant hepatitis can be caused by so many things, right? So in those cases, we normally have a panlobular necrosis and only the bile ducts are left there, okay. The hepatocytes are not there. Now, when we are having a viral hepatitis, how soon can you expect a complete clinical and biochemical recovery? That is the next question which we want to know. So, a complete clinical and biochemical recovery occurs 1 to 2 months after hepatitis A and E. What are hepatitis A and E? These are the fecal-oral route of transmission, fecal-oral route transmitted viral hepatitis. In the other things, it takes almost 3 to 4 months after the onset of the jaundice. That is hepatitis B and C, right? So now what is chronic viral hepatitis? When you are having, that is one of the sequelae of your acute hepatitis, right? When you are having a chronic hepatitis, when do you define it as a chronic hepatitis? When you are having a persistent inflammation for more than 6 months or longer, and it is usually because of the parenterally transmitted viral hepatitis infections which cause chronic viral hepatitis, okay. So viral markers, HBS, you are having antigens and antibodies, antigens to the surface antigen and the core antigens, okay. HBsAg and HBeAg, it is a late incubation phase and highly infectious. When you are having both the antigens with anti-HBC, anti-core antibody, okay, that is also again highly infectious. When this HBe antigen is disappearing, when this HBe antigen is disappearing, but HBsAg and anti-HBs both are there, they are still infectious. They are called as simple carriers. Okay, they are carriers, right? HBsAg and both the anti-HBc and anti-HBe antigens are positive. It is a acute hepatitis with low infectivity. When both the antigens are absent and all the three antibodies are present, it is late convalescence. And only anti-HBsAg is positive, it is a vaccinated individual. This is how you will decide about the viral hepatitis B. Now, how does it look like on microscopy? The chronic viral hepatitis has a mononuclear portal infiltration. If you keenly observe, the inflammation is only at the portal tracts. The parenchyma is not involved in your chronic hepatitis. If at all it is involved, it is only the interface hepatitis. That is only the limiting plate and the hepatocytes which are around your portal tracts are getting involved. And then we also have extensive fibrosis and scar formation, which ultimately leads to cirrhosis formation. And then we are also having a stem cell activity which leads to nodule formation. This is what is the light microscopic picture of chronic viral hepatitis. What is the light microscopic picture of acute viral hepatitis? It is a necrosis and inflammation usually of your parenchyma. But whereas in your chronic viral hepatitis, it is your portal tract which is inflamed, and in both cases it is the lymphocyte only which is present, right? So it is in the portal tract, and if at all there is a parenchymal, it is only periportal, that is called as interface hepatitis. And then the other feature is your fibrosis. If you remember, what is chronic inflammation? Chronic inflammation is where you are having an ongoing inflammatory process and the repair, both occurring, repair and ongoing necrosis, ongoing inflammation and ongoing repair by fibrosis, which is occurring all together, is chronic inflammation. The same thing we are finding here in the chronic viral hepatitis, is it not? So you are having a chronic viral, you are having a chronic mononuclear portal infiltration, interface hepatitis and fibrosis. All the three features are there. Okay. And now I think in the last class I forgot to tell you about one thing. Whenever you are having features of chronic hepatitis along with these features of fatty degeneration, it is usually hepatitis C infection. And the second one is also whenever you are having a lymphoid follicle formation, that is also in favor of hepatitis C inflammation, right? You look at this, there is no necroinflammation of the parenchyma. The inflammation is over the portal tracts, right? And then you have fibrosis like this. So to understand what is the grade and the stage, whenever you are having necrosis along with your portal inflammation, when you are having a necrosis, you call it as grade, you grade that necrosis and you call it as an chronic active hepatitis. Whenever there is only portal inflammation with fibrosis, you call it as a chronic hepatitis with fibrosis, right? So that is the histologic grading and staging. So histologic grading and staging is central to the determination whether you have to treat these cases with interferons or not. So in grading, you are having 4 grades where the activity is minimal. What do you mean by activity? The necrosis of the portal hepatocytes. So it can be minimal, mild, moderate or severe. Interface hepatitis, focal and involving most portal tracts, circumferential and involving all portal tracts. Then lobular inflammation is depending again on yes to no, no to maximum. It is the activity. This is how it is graded. This is the activity, right? So whenever this activity is more, you call it as chronic active hepatitis, and this is the stage where it tells you how much % of cirrhosis is present in these patients. Okay. So in acute inflammation, the pattern of inflammation is in the portal and the parenchyma, and parenchyma being the maximum. In chronic, it is the portal and the periportal which is present, and cholestatic features are common in acute and not in the chronic. Fibrosis is also mild in acute and progressive in cirrhosis, right? So inflammation and necrosis more in the parenchyma. In the portal tracts, very mild. Here inflammation and fibrosis in the portal tracts, and here it is less. Coming to HIV infections, carrier states, chronic hepatitis and all these things are absent in HIV infections, and fulminant hepatitis can occur in these cases. HBV, all the stages are there. Carrier state can be there, chronic hepatitis and also fulminant hepatitis. In HCV, fulminant hepatitis almost nil. HDV, you have a more higher rates of fulminant hepatitis, and the chronic hepatitis and the carrier states are also present. HEV, fulminant hepatitis is very common of HEV patient in pregnant women. HEV infection in pregnant women. So when you are having an acute viral infection, most of the times it is subclinical infection and they recover. Okay. Then 20% of the times go to acute hepatitis. So if it is spotty necrosis, which is 99%, they recover. If it is the panlobular necrosis, it goes to fulminant hepatitis and death. Okay. And then there is a fraction which are healthy carriers. No symptoms, but they are carriers. Okay. And then if the infection persists, again here 90% recover. Of these 4% of the persistent infection, 1/3 of them will develop chronic hepatitis, and of this 1/3, 50% of them will end up with cirrhosis and 10% will have hepatocellular carcinoma. Yes, this is the clinico-pathological syndrome of your viral hepatitis. Acute subclinical anicteric, symptomatic or icteric phase, fulminant hepatitis, cholestatic hepatitis and atypical presentation, whereas chronic is asymptomatic without hepatocyte necrosis, chronic infection with hepatic injury, chronic hepatitis compensated with cirrhosis, decompensated chronic hepatitis with cirrhosis, and chronic post transplant cirrhosis. Then coming to the major portion of the cause of cirrhosis, alcoholic liver disease. We are having 3 stages here. Alcoholic liver disease is steatosis, steatohepatitis, steatofibrosis, finally ending up in cirrhosis, right? Why is this happening? It is happening because of acetaldehyde, which is an intermediate. How is acetaldehyde formed? Most of the times the ethanol is getting converted to acetaldehyde in the cytosol by alcohol dehydrogenase. Then some of it is also converted in the microsomes and some of it in the peroxisomes by use of catalases. And this acetaldehyde, it again gets converted into the acetic acid. And now this acetaldehyde is the hepatotoxin, and it is causing a diversion of the metabolism to alcohol. So from all the sides, the fats are getting accumulated in the hepatocyte. Okay. So metabolite and hepatotoxin, diversion of the fat metabolism and fat storage, increased peripheral release of the fatty acids, fat storage and fatty change, now rupture, necrosis, inflammation and fibrosis. Then alcohol by itself is a collagen synthesis, collagen stimulator. Inflammation, portal bridging leads to micronodular cirrhosis. So initially microvesicular fat globules are formed, which coalesce to form a macrovesicular fat globule and the fatty change. This is how we find in our H&E stain sections. What is steatohepatitis? Steatohepatitis, in addition to the fatty change, we have ballooning degeneration, necrosis, inflammatory cells, Mallory bodies, which are the agglutination of the intermediate filaments, and then we are also having perivenular and pericellular fibrosis. Okay. Steatohepatitis, hepatocyte swelling and necrosis, Mallory-Denk bodies, neutrophilic reaction. These are the 3 features of your steatohepatitis. What is steatohepatitis? Along with fatty necrosis, we also have ballooning degeneration, Mallory-Denk body formation and neutrophilic reaction. And then pericellular fibrosis and pericentral lobular fibrosis starts occurring in alcohol, and that finally leads to cirrhosis, which is called as Linux cirrhosis. And in cases of cirrhosis, if there is abstinence, there is a better survival. When alcohol is continued, they succumb to the death. Right? So that was all. The gist of cirrhosis, the causes of cirrhosis, and also the gist of your liver diseases. Right? Okay.